come. No, no, just
Okay.
no, JSS. Mamta may not be.
I'll just open up the screen whenever you're ready. Yeah.
Yeah, now the projection is fine.
Okay. Can you hear my voice as well?
Yeah. Now audio, video, both fine.
Excellent. Right. Okay. I'm ready to go whenever you want me to.
Yeah. You will just wait for another 7-8 minutes.
Yeah, that's fine. Yeah.
Okay.
So are you guys doing any elective surgeries, or have you, I mean, I saw that you had to reduce the amount of elective activities in the last week or so, particularly?
Yeah, we had to reduce significantly because patients getting operated, surgeons, nurses, everybody is getting positive. So we had to reduce. Mostly it is a community transmission has developed in a very rampant way.
Yeah.
Probably not from the healthcare setting, probably it's from the community as well.
And I suppose, I mean, at the moment, are you all deployed into critical care as well, or because we had something like 22 intensivists, then we had about nearly 150 anesthetists, and what we had to do is when these elective surgeries were stopped, we had to bring everybody, and we ended up with expanding up to another 100 beds, and all the in our hospital, almost all of the orthopedic, urology, GI, and including the liver transplant surgeons, pretty much all of them were doing medicine for a change.
Yeah, that's what almost we also did. But we feel the next 4 weeks will be really challenging. We'll just wait for another 5 minutes.
Okay.
Yeah, okay. Very, very high.
So did you prepare it in such a way that it runs for, because you originally told me for about half an hour and 20 minutes, but I've got enough to go for about 45 minutes. That'd be enough for you?
So that's fine.
If I go over it, you can probably give me a shout and then I can stop. But if I finish off, I probably will be about 40-45 minutes.
No issues, that's fine. Is it live on YouTube now? You sent to me in WhatsApp? Yes.
Okay. About an hour.
Hello.
Oh, hi.
I hope I'm in time, Dr. Biju.
Oh, hello, Dr. Vasudevan.
Hello, Dr. Elankumaran. How do you do?
I'm very well. How are you?
Sorry, it's a bit tight schedule. I was supposed to
No,
join a few minutes earlier. I apologize for that.
no. That's. I mean, I
Oh,
can fully understand. We were very similar in
okay,
March, April, but we are a little less busy now.
okay. Your voice is a bit low, the loudness. Can you
Can
step
you
it
hear
up?
me now? Is that better?
Yes, little better, but maybe it's on my side some problem. Biju, how is it on your side? Is the audio good?
Yeah, my side is fine.
Okay. I think Dr. Kumaran, you may have to step up your mic input volume or something.
I don't have a mic. The mic is attached
Okay. Okay.
to the computer, but I can talk loud. Can you hear me now?
Yeah,
Yeah.
far better, but looks like you may have to struggle a bit.
Well, I mean, I prepared it for about 45 minutes, so if I
Okay,
can,
okay,
if
okay,
I'll try and keep up with it. Maybe I'll get a glass
okay.
of water or something. It should be all right.
Yeah,
Is this voice enough? Can you hear me now?
yeah, it's good enough. It's good enough.
Yeah.
That's it.
Okay.
Okay.
I have also shared the YouTube link to you.
Okay.
Yeah, it's going live on YouTube now.
I I I can't see any links on my computer, so I probably will just leave it as it
Yeah,
is.
in your WhatsApp,
Yeah. Oh. Okay. Well, I mean, I'm not going
Yeah,
to, I wouldn't be able to look at it. So I'll probably will leave it
yeah,
as
no
it is
problem.
anyway.
It's okay.
So whenever you want me to start, I'm very happy to start. Yeah.
Yeah, just another 4-5 minutes.
Uh, okay.
Yeah. Yeah.
Dr. Kumaran, how long you were there in UK?
So I've been in Leeds now for the last 13 years. Was there
Okay.
when I came here in 1998,
Okay.
and I've been a consultant now for about 12 years now.
Okay. So you're full-time in intensive care, is it?
Well, I was initially full-time intensive care for a couple of years. Then now I'm doing 60% intensive care, and I do 40% respiratory medicine.
Okay. Okay. So how is the COVID status in? Or
Yeah, well,
hospital
it is.
still?
I mean, in the last, particularly the last 3-4 weeks, it is certainly. I mean, we haven't seen any in intensive care for the last 3 weeks. I'm saying that now. I don't know what's going to happen tomorrow, but
Okay.
in the last 3 weeks, we haven't actually admitted anybody with a new case of COVID in the last 3
Okay.
weeks.
So we still are in the ascent. I don't know when we are going to reach the peak. Hopefully in the next
It
4
will.
weeks.
I mean, you will. It will be. It will come down. It will be a few
Yeah.
weeks, but I'm sure it will die down because the more it normally takes about 2 to 3 weeks from the time you put in all these restrictions in terms of people moving around and the shutdowns and things, and you will see the effect. But it takes about 2 to 3 weeks. So by that time, you will start seeing the effect of it. The only thing is, it has taken a good 3 to 4 months for us, even in a
Okay.
population that is like something like
Okay.
8 lakhs or 800,000 here. I mean,
Okay.
it has taken about 4 months to eventually come to a point of seeing less number of cases.
Okay.
So it will take a few. My guess is a few weeks for you, at least a few weeks.
We had a lot of time to prepare. Still, in the last 1 month, we are kind of pushed heavily. We are feeling the pinch now.
I can imagine, and it's not just one thing or the other, isn't it? It would be anybody from people who go off sick and to people and anything up to simple things, even gets tougher. Oxygen supplies, beds, everything else, I suppose.
The whole hospital has stepped in. Still, we are able to manage the non-COVID emergencies by the side. So
That is
that's
that is
somehow we're able to
fantastic.
manage that
Actually,
also.
that is fantastic. I mean, if you are maintaining a non-COVID service, that is a big credit because I mean, there was a point in our system where we literally had to stop everything because we had that many admissions.
So we don't know when this is going to end. We can't keep on delaying all those other patients. So we have to treat them equally. So
I know.
Juggling both is a tough job that we're facing now.
And I mean, there is no rights and wrongs, and you cannot do the same
Yeah,
for
that's true.
everybody,
That's true.
and you don't
That's
know
true.
you,
It's
you
absolutely
don't know whether what you're deciding is one person's gain, is one person's loss, and unfortunately, you would still have to rationalize, and
okay.
I don't think any one of us would be prepared for this. And, but you will see the end. I mean, I'm sure you will. And what we did in the beginning, and what
Yeah.
we faced, and what we evolved in the next couple of weeks or couple of months, did help us. And what you learn makes you to adjust. And many times, once a couple of months goes by, you will learn to be able to cope up with that demand and readjust.
Yeah, that's exactly what you're doing. Learn to live with it. COVID is part of the
You
life
can
now.
have.
Yeah, can we
I mean,
start
everything I
now?
can tell you that helps
Yes,
you
yes,
out
yes,
in
Dr. Biju. Biju, you're the boss.
Yeah, can we start now?
yeah, every setting is slightly different. But if
Yeah.
I say something that helps you with any of those, that would be
Okay,
fantastic.
okay, Dr. Kumar. Dr. Biju said we can start the session now.
Okay,
So,
so
Yeah,
I'll
Dr.
start
can
Biju?
we
my.
start now?
So
Yeah.
Sure, sure, Dr. Biju, sure.
Yeah. Okay. So, good afternoon to all, and welcome to the scientific session of JIPMER Scientific Society. And along with me in studio, Dr. Durga, our Joint Secretary of the Scientific Society. And today, the talk is about COVID, the management of the sick patients. Today, we have an eminent speaker with us. Dr. Ilankumaran Paramasivam is a consultant, pulmonologist and critical care specialist at Leeds St. James Hospital, UK. He graduated from Madras Medical College and did his MD at Stanley. Then he went to UK and attained his MRCP, and he was also a member of the European Society of Intensive Care. And his basic area of interest is respiratory critical care and interventional pulmonology. And he is actively involved in management of COVID patients, those critically ill. And in the research front, he is a member of the research committee on COVID at Leeds. And he is also a principal investigator of a multi-centric trial of adaptive platform trial for COVID pneumonia patients. So we have an eminent speaker with us. And on behalf of JIPMER Scientific Society and JIPMER, I welcome Dr. Ilankumara Paramasivam for the talk. And I also request Dr. Vasudevan, Head of Anesthesiology and Critical Care, to co-chair the session. Dr. Vasu, please.
Thank you, Dr. Biju. Without taking much further time, I would hand over the dais to the virtual dais to Dr. Ilan Kumaran. Dr. Ilan Kumaran, please.
good afternoon to you all. Thank you for inviting me to talk on this JIPMER Scientific Society, and thank you for all of you to listen to this. And without my any more time wasting, I'll start straight into the topic. Today, in the next half an hour to 40 minutes, I'm going to talk about the intensive care and ventilatory management of severely ill COVID patients, which I've been asked to share, which I'll be delighted to. And I really hope that I could share some of our experiences from Leeds, which would help you in this current time of your peak of your pandemic. So the information about the amount of the pathogenesis, the clinical course of the disease, the treatment options, all these things are rapidly evolving. There is a wealth of information that is coming out almost on a daily basis. So for the purposes of this talk, these are the resources that I've primarily used. The first resource that I've used is the National Institute of Clinical Excellence. The second one is the Intensive Care National Audit and Research Center data, which is collected for all the 250 odd intensive cares throughout the England. I have also used the guidelines, which have evolved in the last couple of months. One is the surviving sepsis guidelines for COVID-19, and then the other one is the World Health Organization guidelines. Some of what I'm going to tell you, unfortunately, is going to be personal opinions and consensus statements. This is because in an ideal world, we would like to have evidence base for all the things that we talk, but the situation is evolving so rapidly that many times you end up with these personal opinions. So to kickstart, where you are now is where we were in about around end of March, beginning of April. So in the north of England, in Leeds, we started seeing our first patient towards the end of March, and within the first few weeks, the number of cases that we had rapidly went up, and by the time we were in the beginning few weeks of April, all the way down to the end of April, we had a significant increase in the number of patients. Now, this data that I'm showing to you is a nationwide data, and we had our peak in England at that same time. And over the last few weeks, we have certainly had less number of patients. Just to give you a background about our hospital, our Leeds Teaching Hospital is a university hospital. It's a referral center for solid organ transplants, oncology, hematological malignancies. It's also a major trauma center and neurosurgery. So one of the things that made a big impact is the impact of the COVID on these other services as well. We had 2,000 patients, as in 2,000 beds in patient beds. Our critical care capacity at any one time was up to 120 critical care beds. Overall, in the last 4 months, we've had more than 500 admissions with COVID in the hospital, and we've had nearly up to more than 150 admissions to critical care. So when we started the COVID pandemic, and this is way back in March, at that time, we were simply thinking of COVID as either a suspected case or a probable case or a confirmed case. Well, this is primarily because at that time, the testing, the availability of the testing was less, and we were thinking more about a diagnosis rather than severity at that stage. So the case definition was pretty much in terms of a normal, any pneumonia that anybody presents with, which is cough, fever, shortness of breath, and a contact with anybody who had a suspected or a high risk of having a COVID. We then had a probable case because the tests at that time weren't specific and sensitive enough. But now, over the last 3 months, we have understood the disease a bit better. We have a better understanding of the course of the disease, how the epidemiology of the disease works. And this has led to the definition and categorization of the disease into 4 categories. In fact, it's actually 3 categories, but the 4th category is just subdivided into 2. The first category, which is the mild illness, and this almost forms nearly about 2/3 or 85% of the patients. Many of these patients are symptomatic, but they might not be symptomatic enough to need to get medical attention. And at the moment, in view of the infectivity of this disease, there is a broad consensus to say that when they do become symptomatic and they're not ill, many of them are advised to stay at home, at least in here. There is a big proportion who are asymptomatic. We won't go too much into that for the purposes of this talk. Now, we would be primarily facing the group of patients who would become symptomatic and would then need to come to the hospital because of the shortness of breath, wherein when we assess them and we find them to be hypoxic, that will be the starting point of our severity of the disease. And the next few slides that I'm going to show you is primarily focused around that bit and the management of that when they end up in intensive care. Now, 2 main clinical assessment points that we do is one is the degree of hypoxia, and the easiest and the most sensitive kit that we use is the pulse oximeter. Now, there are some threshold differences in terms of when you should become a little bit more worried than less worried. It could be anything between 90 to 93%, and we know that once we go down the 92% cutoff mark, the sensitivity of the pulse oximeter becomes not as good as what it is above that. In terms of clinical assessment of the patient, it's very important to look at how the patient feels in terms of distress and the respiratory rate. But in this particular COVID pneumonia, There are some peculiarities in terms of how the patients look as presentations compared to normal pneumonias, which we'll come across. There is a group of patients who do progress. Which one of them progresses and how quickly they progress, we will go through that as we go along, because that would be the crucial part to try and support them during that process of deterioration. So the crucial cutoff points would be saturations of less than 93%, and I would say anything up to 94% would be pretty comfortable. Anything less than 94%, needing any supplementary oxygen would be the starting point. And once you start seeing patients to become distressed and starts to become breathless with respiratory rate, then you really are thinking about this patient needing to be in a critical care environment. And a few of them develop quite severe lung injury. Now, in the beginning part of this COVID pandemic, we didn't have a lot of understanding about the pathogenesis of the disease, but it is rapidly evolved. And this is one area where we have got a fairly good understanding now. Now, the crucial thing with the coronavirus, as opposed to any other virus, is that even in the pre-coronavirus era, in 2003, when we had the SARS pandemic, we knew that the coronavirus has a very specific affinity for certain receptors that are present in the lining of the epithelial cells of the alveoli of the lung. So when a person inhales, because often nasopharyngeal route is the way the patient gets the virus then gets itself attached to the receptor, which is basically a protein enzyme that is termed as an ACE2 receptor. And this is on the lining cells of the alveoli. And once it gets attached to it, the one peculiarity, as opposed to previous coronaviruses, is that this coronavirus has got a spike protein that has got quite a significant amount of bondage to it, which then makes these viruses to become opsonized. And once inside the cell, you can see that I've written a few things like clarithin, vimentin, and ADAM2. These are proteinases, and these are present in the lining of these cells. And with this, along with the receptor, then produces an envelope for the RNA, which then gets into the cell, which then produces more replication of the virus. And as the load of the virus increases, so the epithelial cells start to die out, the free viral DNA starts to get into the circulation through the lymphatics, and they get presented to the antigen presenting cells and then to the macrophages, which then produces a whole host of inflammatory cascade, which leads to a specific set of lung injury. Now, this diagram, the primary pathogenesis of the lung to begin with in the early stages of the disease and progression is because of this affinity of the coronavirus to the receptor. So when we start with a classical renin-angiotensin pathway, you know that angiotensinogen is a large molecule that gets cleaved by the renin to a smaller molecule of angiotensin 1 to begin with, and the angiotensin converting enzyme then cleaves it to angiotensin 2. Angiotensin 2, along with the renin, forms the axis that maintains the blood pressure, the anti-inflammatory pathway, and the fibrinolytic pathway. Now, angiotensin 2 normally has got two receptors that it gets attached to in the alveolar epithelium. There is an angiotensin 1 and an angiotensin 2 receptors. The one receptor produces vasoconstriction, a hypertrophy of the muscles, a fibrosis, a pro-inflammatory and oxidative stress. The affinity to the angiotensin 2 receptor has got a counterproductive effect. And in general, this keeps a balance so that in the lung, there is a normal process of wear and tear. There is a homologue of this ACE enzyme that was discovered way back in 2000, and that was labeled as an ACE2. Now, this enzyme is crucial because it reduces the angiotensin 2 back to angiotensin 1. And angiotensin 1, contrary to 2, has a lot more counter effects, such as vasodilatation, proliferation, anti-fibrosis, and anti-proliferation, and anti-inflammation. So when a coronavirus gets attached to the angiotensin 2 receptor, it downregulates it. And as a result, you just don't have this lysis of the angiotensin 2, which then produces a whole cascade of vasoconstrictive, proliferative, pro-inflammatory, oxidative stress injury to the lung. Early stages, this will be limited to the lung. Later stages, as the viral RNA gets into the bloodstream, activates the macrophages, you then get a systemic injury. And that affects organs such as the pancreas, the heart, the intestine, and the liver. The heart, liver, and the pancreas are particularly affected because they also have a lot of ACE receptors. The free mRNA in the blood, because the endothelium contains ACE receptors, will also produce endotheliitis, which is like almost a generalized vasculitis. What proportion of patients develop this? You could probably say a small proportion if you have a denominator as the overall infected people, which is throughout the population. That will be about 5% of the population, which is relatively less. But if you use the population as the ones that are hospitalized, it could easily mount up quickly because you would be hospitalizing those patients who are symptomatic and who need some level of oxygen support. And in that population, you would probably would have to support the other organs, or at least find other organ injury in about a third to a quarter of the patients. So that'll be about 20 to 30% of the patients. And who are all these patients? Now, these are all epidemiological data. There are lots of scientific explanations for this, but it will be very difficult to know why these people get it and why these factors particularly affect. But there are certain things that are striking. I have used the data from the Intensive Care National Audit Research Center. So this is a graph showing the age at admission to intensive care and the gender. And if you see the middle part, middle age, 50 to 70, male gender, there is a very striking difference in the type of patients and the age group that is affected. Lesser age group and extremes of age groups, less common. When I say extremes, I'm talking 80 plus. I shouldn't probably say that, but 80 plus are less. And this might be partly represented by the limitations of this data, is that we do have some guidelines for what type of patients we admit to critical care. The second part, that seems to have a big striking association with the severe pneumonia, is the body mass index. Those patients who have a body mass index of around 30, and particularly 40 plus, they certainly seem to have it. But this could be a number of factors associated with it. It might be anywhere from lifestyle to other comorbidities to how they are and what the social circumstances and things. But there is an association. So if you have a patient who is in the late 60s and who has a high BMI and who is a male versus a female, there is a higher chance of them developing systemic disease and severe illness. And when does this show up on an X-ray, and what is the time course profile? Now, this is again variable, but we have enough data now to say some broad guidelines on it. We know that the maximum lung involvement peaks around the 10th day from the symptom onset. There are certain radiological features that happen over a period of time, within a week. Not surprisingly, when you get the maximum infiltrate with edema, you get ground glass opacities. These are very subtle at this stage. Most of them tend to be mildly symptomatic and probably mild to moderate hypoxia. Then you develop the lymphatics when these viruses and cytokines are starting to produce more flow, and that produces the crazy paving pattern with interstitial infiltrates. About the end of the first week to second week is when they really develop more consolidations. And there is no clear cut, or at least it is not easy to say what happens at the end of that. But if they are lucky and they start getting better, they do get better at the end of 2 weeks. But if you look at the follow-up results, even though they are not many, you could easily say many of them have radiological abnormalities right up to anywhere up to 12 weeks to 3 months. So we're going to restrict ourselves to the moderate or sick patients. Now, the most problematic part of these patients is the hypoxia, and the second part of it is how much is that different from any other pneumonia. Now, the first part, which is most of the normal pneumonias, you would normally present with a fever, cough, pneumonic symptoms, and many times as the severity of the pneumonia gets worse, so the patient becomes symptomatically worse, and so the hypoxia gets worse. Now, the slight different presentation of the coronavirus is that you could see I've got a partial pressure of oxygen on the x-axis and time course on the y-axis. And when the patient presents initially with a symptom of shortness of breath, they are hypoxic, and they are hypoxic to at least a moderate degree, but they are not very symptomatic. And at this stage, when we talked about the initial parts of the pathogenesis, many of them tend to be having a viral replication with lots of intrapulmonary shunting, which is predominantly a vascular problem inside the lungs with a VQ mismatches. At this stage, they are hypoxic. Supplementary oxygen will improve things, but not always. But in effect, they don't feel very breathless because the lungs are still light and fluffy. So by the time it was around a week to 10 days down the line, when the inflammation starts to pick up, both locally as well as systemically, they then start to get the microthrombi, they then start to develop more consolidations, they then start to feel more breathless, and so that's the hypoxia. But this period is a very short period. So from the onset of around the end of the first week, there is a rapid worsening of clinical picture and there is a rapid worsening of hypoxia. Now, this doesn't always happen, but it sort of gives you a time course of to be cautious around the 7 days once they're admitted. And once they're admitted, and the first part that the critical care or the intensive care or intensivist normally comes across is a point at which these patients need a certain degree of oxygen. And many of these patients, by the nature of the fact that we always wouldn't have enough beds, often get admitted to general wards. And we have a system of the critical care outreach, which would be a physiological score-based trigger system, wherein when these patients get observations like saturations, respiratory rate, and blood pressure, they get a score and they get a trigger for to be called for critical care. Now, one striking feature that you'll often find is when these patients get hospitalized, in the first parts, they tend to be pretty minimally symptomatic. But when you put a pulse oximeter on them, you tend to see that they tend to have a lower saturation than what you would expect them to do. Then you would think whether it's a problem with the saturation, pulse oximeter, etc., but often it tends to be true. Now, there is variable descriptions of this. This is called happy hypoxia and silent hypoxia and things. But I would probably call it more comfortable hypoxia. But they are hypoxic and they will need some supplementary oxygen. And a lot of them tend to stay like this for some time and they tend to get better. But a few of them, over a period of the next few hours to days, would get more breathless. The guide for us would be the saturations and the clinical picture. And once you start somebody on oxygen, the standard approach for us in the United Kingdom would always be a targeted saturation. The targets has to be defined at the point of prescription of an oxygen. And the targets slightly vary depending on whether you're completely healthy, whether you have an underlying lung disease, and whether you have other physiological things like pregnancy. Once you have a target saturation, once you start titrating the oxygen, roughly a trend of requiring more than 40% oxygen at a point when you are still giving it through a face mask or a variable flow device. And once your saturation starts dipping down less than around or around 92% to need 40%, you probably are looking at a patient who's got a potential to deteriorate further. And that would be a point at which we started advising people to have self-proning. Now, this is, even though we have done proning for some time, it's more often that we do it in intensive care rather than in patients who are in the wards. But this particular episode of this coronavirus has made us very aware that when you change the position of the patient, whether the patient lies down on the right side or left side or on his front, there is a significant redistribution of the pulmonary circulation, which does improve the oxygenation of the blood. So at this point, when they need about 40% and more than 40%, and when the saturations are less than 92%, we would advise the patient to have a change of position for as long as they possibly can. And this varies from a patient to patient and varies from the patient's comorbidities and habitus and things. But then this would often tend to last for about a day or a couple of days, where they can then keep on maintaining that level of oxygenation. Then you would see either one of the two courses often tends to either the patient starts to get more tired and more breathless. And when they do that, it would be that over the next few hours, you would see them getting very quickly more uncomfortable. This then moves on to the next territory, which makes a big difference to our treatment in intensive care. Now, this concept of aerosol generating procedure. Now, this concept was originally designed from the previous SARS pandemic some years ago, when 2012-13, this term was labeled as a aerosol generating procedure. The aerosol generation and the procedure was tagged on because of the problems with healthcare workers that happened at the time when people were intubating and doing tracheostomies on these COVID or coronavirus patients in 2012. The World Health Organization defines the droplets as something that is between 5 to 10 micrometers, and that is less than 5 is classed as aerosols. Any procedure that produces a forcible spray of air with a flow for the forcible flow of air will produce a spray. Now, the size of the droplets vary, and proximity and time exposure to the patient with respiratory distress are strong determinants of risk rather than the actual procedure. So in a way, at the time when a procedure is done, there is so much precaution that is taken that the likelihood of getting something from a procedure and during the procedure is low. But when the precautions are a little bit less relaxed, and when we have less severe patients who are sitting around in the wards with moderate illness on a moderate amount of oxygen, you see that the proximity and the time makes it much more riskier. So it kind of pans out in that you could see a lot more nurses, a lot more carers, social workers, and a lot more, doctors with direct contact getting affected rather than the people who are actually doing the procedures. So be very aware that even in moderate patients, wherein you're doing anything that forces the air out, will produce a form of a generation. And the longer you are with them and the time that you spend, the higher the chances. And every contact should be very vigilant. Any form of non-invasive respiratory support will have a risk. Then again, high flow oxygen by itself, it's not aerosol generating, provided it is not tagged on to a forcible generation of air. Non-invasive ventilation, choice of non-invasive ventilator support in adult patients with COVID. There are certain devices that you can use for non-invasive ventilation. Now, non-invasive ventilation as a broad rule carries the risk of aerosol generating procedure and risks. And the only reason why we talk about it now is because we cannot have intensive care beds and ventilators for every patient who gets respiratory distress. Otherwise, we probably might not even talk about it. The second point why we talk about it is because those patients who do get ventilated, they certainly have a worse outcome than the ones if at all these non-invasive supports are effective. So among the line of non-invasive supports that we have the high flow nasal oxygen or high flow nasal cannula, which has developed in the last 10 years or so. This had big concerns in this particular pandemic, particularly because this utilizes a fair bit of oxygen in addition to the infection spread. And I have to say, when we started, there was lots of concerns about infection spread with high frequency nasal cannula. But the current last month or so, there's been published evidence that this is considerably less and probably very effective compared to other types of non-invasive ventilation. Non-invasive ventilation in the form of BiPAP or other bi-level ventilations are reserved primarily for patients with hypercapnia. And unless the patients are very closely monitored, it is not a favored type of non-invasive support. Now, CPAP is a preferred form of non-invasive support. Now, this had a major advantage in that the oxygen utilization was better in comparison with the high flow nasal cannula. Now, in our experience, and in the north, this is divided across the country. In England, we still have a very different opinion about whether we should be using CPAP at all on these patients. But we did use it, and we have used it in a fair number of patients. And we had a rough guide to say whenever the oxygen requirements hit 60%, and we had to maintain a saturations of 90%, that's when we would start them and move them to critical care. We used a variety of interfaces from face masks to helmets, but most crucially, every one of them had to be specifically adapted to prevent a spread of a virus from the patient, which includes a a HME filter that you need to attach to the circuit. Once you start the patient on CPAP, that doesn't stop you from continuing with proning. And many of our patients whom we admitted ended up with CPAP and proning, and a lot of them tolerated it well. The peak that we started was around 10 centimeters and increased it up to 12 centimeters. Most of them tolerated well. And moving on with why CPAP is not generally, as a general rule, not a established or even a standard mode of treatment, is because if you look back on the evidence for hypoxic respiratory failure and CPAP, the evidence is very weak in how effective it is in any form of pneumonia. The only place where we have very solid evidence is in pulmonary edema. There are evidence that it helps if you're giving it in the form of high flow nasal cannula or in immunocompromised patients, but equally there are concerns about worsening the situation and potentially delaying things, and maybe also ending up with a difficult scenario when you have to intubate and intervene. In our experience, it did work in a subset of patients. It did avoid intubation in a group of patients, and it allowed, more importantly, for a patient to be admitted when they are awake, when they are intermittently on it, to have a conversation about the implications of what happens if they do become unwell. Because not only will they know whether they will come out or not, they wouldn't even have the opportunity to see the family members because of the problems with infection and things, where limited visiting is allowed at the moment. Over the course of the last few months, not surprisingly, there's lots of literature and lots of editorials about controversies around the use of these CPAPs. This includes the worries about self-induced lung injury or effort-induced lung injury. And this is because of the fact that you have a lung that is inflamed with a biological pool of cytokines, and you have a CPAP that augments the tidal volume. And if the volumes are bigger, it produces a lot of strain and stress, which can augment it. And there's some concerns about these patients might have worse lung injury, but all of these overcomes the worser outcomes when they get intubated. Now, this part of the CPAP usage is subject to each institution and each particular local policy. Now, this is the data from our UK overall usage of the respiratory support. You could see that even if they do get on CPAP, nearly 72% of them end up on ventilation, the blue one being ventilation. But 25% of the patients did survive with just basic respiratory support. This is oxygen and CPAP and other forms of basic support. And a lot of them end up with 65% ended up with a simple cardiovascular support and didn't need advanced support. A third of them ended up in renal failure. This gives you an idea of how long they are likely to stay on average in intensive care when they come in. Those intubated patients, these are variable, but it only gives you a median. You could say that it goes right all the way up to 30 days, but many of them tend to stay for at least 10 to 14 days. If they are on basic respiratory support, they tend to stay around a week to 10 days. Renal support patients often tend to have few weeks. This data and this graph tells you at the end of about nearly 10,000 episodes of critical care in UK, it gives you a broad survival probability of what is the chances when you come to critical care and what type of respiratory support that you need. If you had a basic respiratory support and not receiving mechanical ventilation or could get away without it, you got a pretty good chance of getting out of intensive care, which would be about 70% to 80%. If you get intubated, it isn't bad, but it is certainly about 30% less than what it is with non-invasive support. It would be about 50 to 60%. This is overall UK data. You could see that the curve, the blue curve, particularly drops around the second week. And that's when these patients become really ill. A lot of things happens around that time, which we'll talk about in a minute. And this slide gives you an idea, because we have used it, and we have found that there is a subset that gets better. On this slide, you could see on the extreme left end, you can see the patient characteristics. The middle part tells you the ones that got intubated and survived or died. And then the right-hand side tells you the ones that got basic support that survived and died. Well, you could see that in the brackets, percentages, majority of the ones that are survived in the respiratory basics group are all in the 90s, irrespective of the age group and irrespective of the gender. Whereas on the advanced support, when they get intubated, the percentage falls dramatically after about 60 years of age. And up to 60 years, it is roughly about 1 in 2 chance. But once you cross that point, the chances becomes lesser and lesser. Ethnicity, we had a very similar response in terms of whether you're Asian or Black or mixed. We got a very similar response in that those ones that had a CPAP had a better outcome if they are able to avoid intubation. And comorbidities as well. The comorbidities on the bottom end of the screen tells you that the ones that have more comorbidities where intubation might be more dangerous, they also had a better outcome. Now, intubating a patient with COVID, there is no one fixed rule about when you intubate and what factors makes you to intubate. But there are certain things that certainly comes along with intubation. It's a very high risk procedure. It's something that would have to be planned, and it would have to be involved along with the patient and the relatives. And this is very important because the outcomes of these are not very clearly predictable. So planning is crucial. It shouldn't necessarily always purely be based on hypoxia alone. It should be a combination of factors. The most experienced airway operator should be the one who will be doing it. And the hemodynamic instability, in our experience, is not very common. It is rare. And of course, every institution would have their own protocols for it. Now, once you intubate these patients, and if they get intubated, now this was published literally about 2 weeks ago from Imperial College in London, and they have looked at 10 patients, postmortem findings in severe COVID, who eventually died, and they have done an extensive analysis of the lungs and every other part of the tissue, and the 4 cardinal features that you find in these lungs. Because there is various definitions of this ARDS being defined as whether is it ARDS or is it not ARDS. But one thing for sure, the pathological changes that you see are very similar. There are diffuse alveolar damage, there is thrombosis, there is hemophagocytosis, and there is immune cell depletion. If they look at the other sites, there were some surprise findings of a certain type or any type of fungus in the lung. Now, this doesn't necessarily mean that they produced an infection, but it certainly means that they are very vulnerable for secondary infections. A lot of them had mild to moderate pancreatitis. Pancreas contains a lot of ACE receptors, and a lot of them had microinfarcts in the adrenals. So if you translate it to then say on the bedside, if I can try and crystallize the 3 major issues that you would face when you ventilate these patients, you could put them into 3 broad categories. Of course, there are lots of other issues. But the first issue would be hypoxia. The second issue would be coagulopathy. And the third issue, once you cross the first few days, would be secondary bacterial infections. And these pretty much cover a broad range of challenges that you would face once you intubate these patients. Hypoxia. Now, we know very well that when you start ventilating patients, you have to sedate them. And we know that the longer you sedate, the deeper you sedate, the more they get diaphragmatic dysfunction and the more complications they get. But unfortunately, in COVID patients, you would have to sedate them reasonably well, because when they have dyssynchrony or asynchrony, they tend to cough, they tend to produce lots of sprays, and it tends to produce problems initially. So adequate sedation is crucial. As with any ARDS, we would have to protect the lungs and not produce any iatrogenic damage. Volume controlled ventilation often gives you a better control, but pressure controlled ventilation can also be used. And you would ideally aim for 6 mils of tidal volume, at least up to 8 mils of tidal volume. You would try to limit the plateau pressures to try to be less than 30. And if you can keep the driving pressures less than 14, this would be ideal. We know very well that in a day-to-day practice, these settings are not easy to achieve. And when you try to achieve, the first thing that you often find other than oxygenation is hypercapnia. And many times when you're dealing with hypercapnia, the initial part of it is have to increase the respiratory rate, and you have to try and think about minimizing the dead space. And this is particularly because in some of these ventilators that are not designed to be ICU ventilators, and when you are putting in extra HME filters or other filters to try and reduce the infection rate, they can quickly get very long. And to try and manage the hypercapnia, you would try to initially address the rate and reduce the dead space. but there is always going to be a level of hypercapnia. You've got to be able to accept it. How much do you accept? Is the level of hypercapnia where a patient has to then be particularly ventilated hard? Now that depends on individual patients' other metabolic status and hemodynamic instability, because they get acidotic, and the more acidotic they get, the more they become unstable. The second part of the mechanical ventilation, as anybody knows, is the adjustment of the PEEP. Now we know from the original ARDS studies that the higher the FiO2 requirement, the higher the PEEP that you need. And the idea is you open up the lungs, you have more alveoli, and you get a more oxygenation. In COVID, in the initial setting and response to PEEP, when you start the patient, there are several ways of setting this up, and many times you would intubate a patient when they are on 80 to 90% oxygen, and that might be one of the reasons why you're intubating. Invariably means you end up with a very high PEEP to start with, as per the ARDS trials. Many times you would find that they don't need this high PEEPs to begin with. And this would have to be almost an individual patient by patient assessment. And there are several ways of doing it. And everybody has depending on the setting, depending on the ventilator, depending on people's familiarity, there are different ways of adjusting these PEEPs. But the crucial thing to remember is at this stage, there are certain descriptions of the lung that people have done that helps us to understand how we adjust these PEEPs in the beginning part. And that we'll come to these phenotypes in the next couple of slides. The idea is you're trying to target a certain level of oxygen delivery, and you're trying to keep the ventilator-induced lung injury to the minimum. But one thing to remember is in the beginning stages, when you intubate somebody and start to ventilate, many times the problem, there is a type of lung injury they have, a phenotype, in which the predominant problem is a hypoxia secondary to vasoconstriction and emboli, in which case, what you do by increasing the PEEP, as you would normally do, means that the hypoxia might get worse. And we know that it gets worse because you have a shunt, because there are lots of these perfused alveoli that do not get ventilated. Now, calculating a shunt fraction is the best tool, and it gives you a rough idea of the magnitude of the shunt, the alveolar arterial gradient. There are validated and described tools to look at the physiological dead spaces, and this can be done by the bedside, looking at the blood gases and looking at end-tidal CO2 and getting a ratio of that. And that tells you to adjust both the dead space physiologically as well as the shunt fraction to adjust the PEEP. Now, one of the things that we found is when you have a patient who has a very easy ventilation, a not big response to PEEP, one of the things, and you have a big shunt, one of the things that you would have to be aware of in these patients is the early assessment of a right ventricular dysfunction. Some of them have high volume pulmonary emboli and they develop a right ventricular dysfunction very quickly. So beware of this in the first few hours to days of ventilation. Many of these patients at the early stage tend to be still significantly hypoxic on 60, 70, 80%. So we would have to prone them. In the early stages, when you prone them, they have a lot of response, a significant response, and the oxygenation comes down quite dramatically. This is put down to because of the early stages, you have a viral replication, you have an angiotensin that's floating around, you have vasoconstriction, you have a redistribution of pulmonary circulation. So there is a big improvement. But as the disease progresses, so the lung gets solid, the amount of advantage that you get by redistribution becomes lesser and lesser. It improves oxygenation, it improves hypercapnia. So how long do you prone them? Once you prone them, I mean, we know that if you prone them less than 12 hours, even if they don't get an improvement, it would not be, it is not advised to do that, purely because proning carries a risk, and you do not want to re-prone somebody within less than 12 hours. Once they respond, to keep them prone for more than 16 hours, sometimes you might have to do this, often leads to pressure sores. But if you have to do it, at least a few hours of putting them back is essential. Other things that we do, that often we do it in many other circumstances in intensive care, is that some of these patients tend to always have spontaneous breaths. And this not only desynchronizes the ventilator, but it reduces the compliance of the chest wall. So in these patients, it's very often that you might end up with a continuous infusion of a neuromuscular blockade agent. And in some patients, once you know that these are the type of phenotypes where there is a big shunt and you're trying to improve the pulmonary vasculature, there is the options of using nitric oxide or iloprost infusions. Now you have to have this as a backup, and you have to have a very clear plan of what you're looking for as a response and how you're using it as a trial. In our experience, or at least in my experience, this is very variable, and many times these type of phenotypic patients do not have a lot of response to it. But it might be that it might borrow time enough for them to be able to tidy over a short period of time when you're not able to do anything else. Of course, these patients do have a lot of extravascular lung water, so strict fluid therapy and keep them dry right from the beginning onwards. It seldom is effective. Bronchoscopy is minimally effective. They don't have much secretions. Recruitment maneuver. In terms of recruitment maneuvers, adjusting PEEP is more dependent on the phenotype, and it's variable over time. Any other maneuvers, you do not want to break the circuit, so bag masking and taking off the ventilator is never advised. Incremental from high PEEP to low PEEP is generally not advised because of the very inflamed lung. An ascending or a stepwise increase in PEEP is much better tolerated. And of course, if all these things do not work, you would have to refer them to an ECMO. Now, one of the things that we learned is, now that we have an idea about the phenotypes, and if you had a phenotype with a predominant shunt and a patient who doesn't respond to proning, an early referral to ECMO and exploration of that side is very essential, because many patients often tend to deteriorate if they are of that phenotype, and you might not have a lot of time for them to go on to have the ECMO. So now that I'm talking about these phenotypes, a quick word about these phenotypes. And this is the reason why it's important that we understand this is because when you are by the bedside and when you're trying to oxygenate them using the ventilator, the idea that there are phenotypes and there are different stages of the lung gives you an idea of what to expect and what not to do. In the early stages, the main characteristic feature of the ARDS is the severity of hypoxia and the maintenance of relatively good respiratory mechanics. At this stage, the predominant problem is one of vasoconstriction, and many times you tend to have easy compliance of the lung. The lung pathology evolves over the neck for the first few hours after the intubation, reflected on changing mechanics. And at that point, when your PEEP initially was very low, you might have to then titrate up the PEEP as you would do with traditional ARDS. And this is one of the patients that we had. And in the first 24 hours, you could see that the patient had a minimal amount of ground glass opacity in the basis, and this is another very characteristic feature. And the later days, within a week, you could see that they are developing lots of consolidation. And if we then match it up to the gas exchange and pulmonary mechanics, you could see that there is an L type and a H type, and this is because the L is light when your lungs are fluffy and easy, and when your PF ratio is better in the early stages, the compliance is easy, the PEEP requirement is low. Then in the next few days, you see that it becomes more hypoxic, less compliant, and needing a traditional approach to the ARDS. So in other words, the time course of it's like a continuous spectrum that you see. Other things that you've got to be aware of in these patients is that they do develop a severe bacterial infection. And when they develop it, it is severe. So it is severe sepsis. And some of them develop a profound septic shock. And as with a normal septic shock guidelines that we do, you would treat them with a targeted map of about 60 to 65 millimeters of mercury. But beware that they are very fluid responsive. So it's advised not to give too much fluids and rather use vasopressors. If they had very profound cardiogenic shock, be aware that there is a group of patients who develop massive pulmonary embolism, and often it tends to be right heart failure. And most of the patients do have a troponin rise with elevated cardiac enzymes. They very seldom have a left ventricular problem. The second part is the coagulopathy. Now, the coagulopathy, by the word of it, would normally mean that it's a problem with coagulation. But in COVID pneumonia, it is a slightly different picture because it kind of represents a pro-inflammatory state. And this results in an activation of complement. It leads to systemic pro-inflammatory cytokines. This results in microthrombi. And there is a spectrum from something about a mild prothrombotic picture to something about a full-blown a macrophage activation syndrome. But the crucial part to remember about the coagulopathy is that this is part of a pro-inflammatory process. So when you're treating the coagulopathy, it's the approach to that should be in tandem with what's happening with the pro-inflammatory picture. So to begin with, we would anticoagulate these patients as a routine for thromboprophylaxis. And once they become more hypoxic and show hyperinflammatory state with a high D-dimer and ferritin, you would also have to think that they would need a higher dose of the anticoagulation because this tags in with a pro-inflammatory picture, even if they don't have any clots. So you would give a higher dose of the enhanced thromboprophylaxis. And as soon as you have a phenotype that looks like as if they have a pulmonary embolism, or you have a CTPA, or you have an echocardiographic evidence of right heart failure, or there is a cardiac insult, you should think about a microvascular thrombus, and you should have a lower threshold to fully anticoagulate these people. And of course, in patients with embolism, you would have to anticoagulate them anyway. Now, there are variable descriptions of potential bleeding in these patients. So it's better if you have the facility to target it for specific anti-10A levels. And this is a suggested guide from Guys and Tommies and from the hematological group to target certain levels of anti-10A factor to give the dose of the anticoagulation. Many of them develop multi-organ failure. They develop raised liver enzymes. And this is particularly important because many of the investigational antiviral drugs produce hepatotoxicity. So it's more of that rather than a fulminant hepatic failure. Renal failure presents in about a third of patients. And when they present with renal failure, you can almost say that those are the subset that really do not do well. The liver injury by itself doesn't prognosticate, but the renal injury does. So like any other condition, the presence of significant comorbidities, the presence of a cardiac injury with a significant troponin rise, the presence of a significant hypo or hyperinflammatory response. Now this happens not in every patient who comes to ICU, but in those patients who does have it, and you can only pick up when you screen them for it, which includes ferritin and D-dimer and keeping an eye on the lymphocyte count, which often tends to give you an idea, and the platelets. If they have a profile that suggests hyper or hypoimmune response, they tend to do worse, as opposed to the ones that do not. And of course, severe coagulopathy and the presence of secondary bacterial infection makes them to have a poor outcome. The second part that I wanted to talk about is the potential disease-modifying treatments that we have for severely ill COVID patients in intensive care. Now, these are the current terminology that we use is investigational agents. We don't call them drugs, we don't call them treatments. That's probably because we haven't had enough time to have a robust evidence for whether how effective they are going to be. So I'm going to stick to something very specific to intensive care and patients who are severely ill. And I'm going to stick to try and give you a steer on what would be a broadly general treatment on this side. The first thing, you can probably broadly divide them into 4 categories. First, these are much more effective in the early stage of disease, but in a later stage, they have less magnitude infection. If you then the steroids, you have the immune modulators, and then you have the convalescent plasma immunoglobulin. If we think about the disease progression, now there is an early stage of the disease where there is the COVID virus in the lung activating the alveolar macrophages and circulating within the lung, some of them spilling over into the bloodstream. Then you have the later stage, severe stage, where you get a systemic activation. So targeting the early phase would involve targeting the virus replication and the lung inflammation and the spread into the blood vessels. Later stage targets includes the modification of the immune system and potentially reducing or limiting the damage. So broadly speaking, the first part of it, the treatment at various stages, including the severity, you could say at the viremic stage, the broad focus would be around the antivirals. Now this reduces the symptoms, minimizes the contagiousness, and potentially reduces the progression of the disease. I've said potentially because I do not think that we have got enough evidence to say that one stops it or not. Then you have the pneumonic phase. At this stage, again, there are some antivirals, but then the other part that makes the difference with the anti-inflammatories, and of which the cheapest, easiest would be the corticosteroids. You would have to be careful about the microthrombi. Anticoagulation forms core in that part. And then you have the convalescent plasma at this stage. The later part, which is often what we see in ventilated patients, is when you want to try and limit the damage and progression of the multi-organ failure. And that almost entirely revolves around limiting secondary bacterial infection and trying to support the immune system. How much you can modify it, what pathways can you block, and what group of patients benefit from what type of immune modulation. Now that would be very individual patient dependent. Now, those patients that gets hospitalized and who are the ones that we are talking about, the one thing that we do currently as a standard is that we do give them dexamethasone. Now, this is almost universally done now. Now, the dexamethasone is given at a dose of about 6 milligrams as a standard dose, which works out to about 0.2 milligrams per kilogram body weight. You can give an equivalent dose of methylprednisolone as well. And this would be started as early as possible when you need the oxygen. And I will share you the trial, the recovery trial, that showed the difference in those people that had it and didn't have it in terms of admission to critical care. And then the second part, that there is a stage at this point where if you are able to screen these patients for a set of immune dysfunctions, and you can target certain immune dysfunctions, and this includes a few IL-6 inhibitors or IL-1 inhibitors and other types of immune modulation. But this, at this stage, and the efficacy of these is very much at the moment not yet clear. But they would need to be moved to a critical care facility at this stage. Now then you move on to the stage where we are, which is in intensive care. Now the things that we do in UK for sure is at the moment is that we use an antiviral, which is remdesivir, based on a trial, which I'll show you in a minute, a randomized controlled trial. Even though it's not very robust, it is the one that we have. We give them steroids, we give them anticoagulation depending on the severity. We then use the immune modulation based on the set of biochemical tests. We don't do it as a routine. Plus, convalescent plasma immunoglobulin therapy is part of a clinical trial in UK. We don't do it as a routine. Now, this is the primary trial that we use to license it and give it for severely COVID patients. The adaptive COVID-19 treatment trial, we were part of the trial. This is on patients who are mechanically ventilated, and the exclusions were predominantly the ones that had severe liver dearrangement and significant renal failure. But even though I was saying that needing hemodialysis and filtration is an exclusion, you could potentially use them in this category. Pregnancy and breastfeeding would be a relative contraindication. In this group of patients, if you look at the trial evidence, I have circled it for highlighting it as lots of information on that slide. The crucial part of it is that there is a difference in the duration of time to recovery. And this was statistically significant. The reduction was about 4 days, from 2 weeks to 11 days. There was no major difference in terms of the overall mortality. So in the ventilated group, even though this is a approved, well-used drug, the actual impact of it is relatively less. Then we have the recovery trial. Now, the recovery trial is a trial that is more pragmatic. So all patients who had a confirmed COVID positive was included. There was no big exclusion criteria. And if you look at the difference between the various groups and the dexamethasone arm in the invasive group, that ended up the ones that ended up with mortality was about 29%, as opposed to the usual care group, which was nearly 41%. So there was nearly a 12% difference between the groups. Those patients that received oxygen and to be in hospital also had an improvement, but it's only less. It's about 3 to 4%. Those that didn't get oxygen, surprisingly, they had worse outcome. As you can see, that the usual care group had a better outcome. So in mechanically ventilated patients, if we compare these two trials, there is a percentage survival. On the left, you have the remdesivir trial showing the placebo mortality of 20%. Remdesivir was 22%. The difference was about 1.6%. Whereas in the recovery arm for the dexamethasone, there was a difference of nearly 12% between the ventilated groups. Those patients that were moderately ill, again, there was a benefit, but the benefit was relatively less in terms of dexamethasone, about 3%, and remdesivir, again, around 8.4%. Those patients with room air, there is a caution here because dexamethasone potentially can make it worse. Now, this goes in parallel with the other concerns that we had with the previous coronavirus infections, where steroids tend to increase the viral shedding, and there's always been a caution thrown in terms of use of steroids in these viral pneumonias. In the UK, the use of immunomodulation and plasma convalescent therapy is within the trial remits, and there are two large trials that we're conducting at the moment, and this is throughout the UK. First trial is the recovery trial done by Public Health England. The second trial is the REMAP-CAP trial. This is done by Intensive Care Society along with the European Intensive Care Society. In these two trials, these are what we call as adaptive trials with the platforms. The platforms originally had the antivirals, then we had the steroids, then we had the anticoagulation arms, then we had immunomodulation, and then we had plasma convalescent immunoglobulin. The antiviral arms originally had hydroxychloroquine and retinovir and lapinavir. Those two are now discontinued. We don't use it anymore, and we use remdesivir as a standard. Steroid arm, again, since dexamethasone has been proven, has been taken out. So we still have the immune modulation arms and the convalescent plasma, and this is how we use it. Now, this is one large observational trial that was published in terms of tocilizumab, which is very widely used. Now, this was an observational trial, and it did show a trend in that there is a subset of patients who do seem to have a survival advantage. But I have to say the randomized control trial that was done by Roche has published that they didn't see a big mortality benefit by the use of tocilizumab. But so this would have to be selected on a case-by-case basis because it's a costly therapy and it does have its risks of immune suppression and secondary bacterial infection. Convalescent plasma, we all know that if you give an antibody that can bind to the protein that is most antigenic, which is the figure B, then it prevents the opsonization and then it reduces the release of the free RNA into the blood. So if you give a large volume antibody and at a right point when the virus is not yet produced multi-organ failure, it does work. And it has been, so not surprisingly, the FDA has approved it now last week, and this was what was published by the FDA. In those patients that are non-intubated, there seemed to be a difference when they get the convalescent plasma. And this is a observational data again, this is not randomized controlled trial. But in terms of ventilated patients, we have given it for 3 patients in here in Leeds, and we have seen a patient recover who did get ventilated, but the effectiveness of the convalescent plasma is not yet clear. So overall, what is the outcome from critical care admission in the UK? This gives you a broad outline at the end of our 10,000 patients. Where the overall survival rate is about 61%, so that is not bad. So that gives you roughly about more than a 1 in 2 chance of surviving critical care. So we had 10,000 patients, as you can see, in total, of which we had 283 patients who are still in critical care. This is about a couple of weeks ago. There's about 6,200 patients who were discharged from critical care. 4,000 of these patients unfortunately died. That gives us about 38% mortality. The very good news is those patients who did get discharged, of 6,000, 448 patients were still in hospital. That's about 7%. 5,488, that's 88% of them got discharged from the hospital. And only about 4.7% subsequently died outside critical care. So there is a period of prolonged recovery. There are many unknowns about the long-lasting effects of the lung injury and the other organ injury. One thing that is emerging is that they tend to be procoagulopathic for a few more days after discharge. So there is a general practice of giving anticoagulation for a few weeks after discharge. The effects of ARDS on the lung developing fibrosis is still very much unknown. A lot of them tend to have mental and physical needs for rehabilitation, and it does have a significant psychological impact. I probably will stop here. Thank you for the opportunity. And this is, I put up some of our patients, and I know that this is a very tough time, but it is remarkable how much patients and how much the multidisciplinary team works in a hospital. And this involves every part of critical care, every nurse, every doctor coming around. And these are a few of our patients. The patient on the left extreme end stayed with us for about a good 60 days. The second patient stayed for 70 days. And this last patient stayed for another 70 days. And all of them had ventilation, intubation, and it is very rewarding when you see them at the end of their very tough period. So I think you're all doing a brilliant job, and all my very best wishes. Thank you very much.
Yeah, thank you, Dr. Ilankumaran, for the nice and detailed and very scientifically and evidence-based talk. And I'm sure there'll be one or two questions. I have one question. You're telling about the phenotype 2, the vascular form of the pulmonary, the lung failure. Is it related to the cytokine storm?
Yes, I suppose this it is. I mean, what we are typically see is that the first couple of days when you ventilate these patients, they are very easy, and then the third, fourth day, by the end of the first week, you then see them starting to develop these bilateral consolidations. Now, there are two, in my mind, there are two parts to this. First part is there is a stage where they're developing the typical ARDS, where they're developing all the exudates and the alveoli are getting filled up. There is the second part where this is the point where they get secondary bacterial infection. So one of the crucial things you need to be aware of at this stage is, yes, it is part of the immune response, but equally, there are two other combinations. One is a microthrombi producing lung infarcts and the secondary bacterial infections. And in my mind, those patients who develop a severe consolidation tend to have a combination of all of these three.
Okay. Yeah, there is one more question. Yeah.
Sir, I'm Dr. Durga Prasad. Sir, what is your experience with ECMO in critical ill patients?
Well, we have a network for referral for ECMO in UK, and in terms of the usage of the ECMO, I know that our nearest centre, which is at Leicester, they have treated up to nearly 50 to 100 patients. Now, there are a few things about that I can say for a general rule from my experience with ECMO patients. Of the patients that we referred, there are a couple of things that we learned right from the beginning. One of the things that we learned is the fact that now we have the idea of what these phenotypes are, which is the particular phenotype with a big shunt and a large volume clot, wherein ventilation not necessarily will make it better. You would have to think about the referral much quicker. That's number one, because there would be a good timeline for them to be able to be established on it. But once they're established on it, they take at least a few weeks. And we have seen some recoveries, but you would have to be having a very good physiology before you start them on ECMO. So the older that you are, the more comorbidities that you have, the less likely that you would be able to survive it. Two major issues. One is the bleeding issue, that there is a fair few of them developing major bleeding because they will all be anticoagulated on top of the coagulopathy that they have with COVID, which is a lot more than normal patients who go through ECMO. And this risk goes exponentially as your age becomes older. And the second risk is the prolonged length of severe weakness they develop, because even otherwise, many of the ventilated COVID patients develop quite severe peripheral weakness. So the ones that go through ECMO tend to have a lot more physical weakness, which makes them have longer hospital admission, secondary bacterial infections. So a lot is there for them to get over. But the ones that are younger, that do get onto ECMO sooner, we have seen some results to come through, but they are less in number.
Yeah. Can you see the chat box? There are two questions there.
I can't see the text box, but
Yeah.
I'm trying to
I'll
see.
read it. Role of driving pressures in PEEP or tidal volume, titration in COVID ARDS.
Okay, well, the first thing, I'll probably take the first one first. I mean, the titration in ARDS. I suppose I did touch upon it when I was talking about it in the beginning. Now, titration, I mean, when you put somebody to sleep on in the beginning part, as I said, many times you tend to be putting patients to, you would intubate patients when they're around 80%, 90% oxygen to begin with. And when you start them, you tend to calculate their ideal body weight as you would normally do, and then you would start them anywhere up to about 8 to 9, around 7 to 8 mils of tidal volume. Depending on the mode that you use, we tend to select the volume control mode. And once you start them at that point, your initial peak when you start, because you're on 80, 90% when you start, we tend to start not at 15 of peak, but we tend to start around 10 of peak. Now, once you do that, and once you have established the patient on a ventilator, then you would have to use the ventilator pretty much along with your blood gases and the respiratory mechanics to titrate two parts. One part is reduced damage because of the high tidal volumes. The second part is the titration of the PEEP to get an ideal oxygenation. Now, in terms of how much PEEP you would then have to go up or down, now that is very subjective to each individual patient's behavior. There is no set fast rule because the general tendency for us in intensive care is always to follow the ARDS protocol based on the original ARDS trial that was published in 2000. The one thing that we have seen is the initial parts, they certainly do not need a very high PEEP as you would normally do. So once you've assessed, maybe start off with a 10 of PEEP, once you've gone up a bit, you might have to come down on the PEEP even with a very high FiO2. So in other words, the titration based on the PEEP would be much less reliable for the oxygenation. You would have to think about other escape maneuvers such as proning, such as vasodilatation of some sort, because purely using recruitment maneuvers alone and titrating the ventilation often doesn't work in the early stages to try and get the hypoxia. I hope it answers what the question was. The second part. The second part, which is
there is one more question. In COVID patients, percutaneous tracheostomy or surgical tracheostomy, which is better?
Well, two things on that. Again, I mean, it is very much you have to. The current practice of doing tracheostomies is almost nearly converted to percutaneous as a broad sweep in intensive care. There is a very significant risk of infection when you're doing a percutaneous tracheostomy. Many of these patients often tend to be severely sick in the first 10 days. So the likelihood that you would be doing a percutaneous tracheostomy within the first 2 weeks is very small because they tend to need frequent proning. They tend to be very severely hypoxic and very oxygen dependent. So often what we have seen is the tracheostomy tends to be around the end of the second week to third week. At the end of the second week, there are certainly a group of patients that would still be positive. But if we do a bronchoscopy prior to that and you have a lavage saying that somebody is negative and you do not have a surgical backup to do a tracheostomy, percutaneous tracheostomy is acceptable, but you need to be able to develop a protocol specifically going step by step to have a ventilation-free period. Because one of the things that happens with a percutaneous technique is that you switch somebody from an endotracheal tube to that of a tracheostomy. And during the switch and starting, there is a break in circuit. And the crucial thing that you need to be aware of is any break in circuit should be done without any ventilator being on. So if we have to do it percutaneously, I think we have done a few percutaneously because it is 2 to 3 weeks down the line. It could be done. You would need to have to prove that there is at least as a minimum negative bronchoalveolar lavage for a COVID. And then you need to have a clear protocol of how you're doing it. And of course, the person who's doing it has to be very experienced, because you do not have a second chance, or at least you try not to develop or try to get into any trouble when you're doing it. In the initial stages, when we had the first few patients, we did go down the route of surgical tracheostomy. But then again, in the later stages, we started doing percutaneous.
Okay, we'll just wait for another 30 seconds for anybody, any extra questions. Yeah.
Okay.
Anybody has any other pressing questions? If not, I think we'll close the session. And yeah, there is somebody who wanted to.
Yeah, I think Dr. Vasudevan wants to ask a question.
Yeah. Can you unmute?
Yeah.
Was?
This is to continue the first question raised by Dr. Pratap. So we talked about the delta P. You said the P we might have to step down at the expense of higher FiO2 in later stages.
Yes.
Are we having any guide to decide optimum P? Somewhere I saw you shown the PV curve and the LAP. Does it really help in these patients to use the minimum required P?
Well, I mean, the one thing that I can say is to try and not stick to the original PRDS peak titration in the beginning part, at least in the first 48 hours. The second part of your question, which is, do we have to go down to the minimum peak? You probably might have to think a little bit more around it, because once you know that from our experience, I can say you probably are going to need a minimum PEEP of around 8 to 10, because there is a certain amount of circuit resistance. There's a certain amount of dead space that you need to get over it. And there is, so to come less than that would be probably not very advisable in most patients, to come less than 8 to PEEP. But to go more than 10, more than 12, more than 15, 18, and 20, now that would be what I was trying to say, is to try and not to think about it in the same way that you would think for a classical ARDS with FiO2. Now, once you are up above the 10, you would have to probably do a trial at 12. And once you've done it, you probably might have to look at it and say, if there's no big improvement, you come back to 10 again. But I would probably say, as a minimum, at least when your FiO2 is more than 60, and when you're proning patients, I would say at least a minimum PEEP of around 10. Around 10 is what is needed for most of the patients.
So it's not just about the alveolar recruitability, but probably because of the diffusion problem that is there, that's probably where the PEEP really has the edge. So we might have to go to the bit on the higher side.
That's exactly right. I mean, think about it, as I said in the beginning part, there is a lot of shunt that happens.
Okay.
That is in a type of patients, not in everybody, but in a type of patient. Because one of the things you also have to remember is not everybody will have pure COVID. If somebody came in with a cough and breathlessness and hypoxia over a period of a week and 10 days, but they also had yellow sputum and they also had suprared infection and other radiological changes suggesting a secondary bacterial infection, then your strategy might be slightly different. But if it is pure COVID, they're lymphopenic, they didn't have any other superadded infection, the radiology is highly suggestive of a ground glass opacity. The problem is one of shunting there. And many times the recruitable alveoli by the PEEP is a lot less at that stage.
Okay. One more quick question. We tend to target an SpO2 of 94 to 96 in most of the patients. But ultimately, our goal should be to ensure tissue oxygenation. So do you recommend any particular hemoglobin level so that the oxygen content is maintained ultimately to achieve the tissue oxygenation goals?
I mean, by itself, we know that we have some trial evidence that liberal versus conservative blood transfusion strategy. We know that the lower limit is around 7 grams for patients who are ventilated. We don't want to necessarily transfuse them unless it's needed, because you're not going to greatly improve the capacity by increasing the hematocrit at that stage. I mean, as long as it is 7 on a ventilated patient, and if it is more than that, then if you're struggling and if you're not able to get them oxygenated to an acceptable PO2, now we can use an SpO2 as a guide, but in patients who are not ventilated, and who have saturations more than 90%, many of them tend to have whatever hemoglobin they have over a period of time. So if there are some of them who are, say, less than 9, they would have had that sort of hemoglobin for some time. And many of them tend to be able to have a degree of acclimatization with that level. And every blood transfusion comes with a risk. So moderate cases, mild cases, patients who are oxygen and not particularly sick and who are not very anemic, doing a blood transfusion to improve the hematocrit probably doesn't have a lot of value. But those patients who are ventilated, wherein they are severely hypoxic, you have done what best you can do, and you're still struggling, or those patients who have cardiovascular abnormalities, like ischemic heart disease and other conditions, or background comorbidities, it would certainly be worth increasing the hemoglobin to right up to 10 grams. But I probably would be very skeptical if you have to increase it any more than that.
Okay, thanks a lot.
Yeah, there is one last critical question is there. How long you will continue anticoagulation in a moderately ill patient?
Well, at the moment, we haven't got a clear guide. I mean, we at the moment are doing it as a minimum of up to 6 weeks, anywhere up to 3 months, depending on each individual patient's profile. There is no one guide to say, every patient should be anticoagulated for a length of time, because recovery after moderate illness is varied, and so every patient has to be judged. But as a minimum, I would have thought that at least a 4 to 6 weeks as a minimum would be broadly something, depending on how sick the patient was. How long do you do it afterwards? I think that would have to be assessed depending on each individual patient's risk. I don't think we have a guide at the moment or some sort of comparator to say one is better than the other.
Okay. Yeah, I think because of the lack of time, we will wind up the session. And on behalf of JIPMER Scientific Society and JIPMER Fraternity, I extend our gratitude to you for this very elaborative scientific talk. And I think this talk was needed at this right moment. And today we realized that we got the mandate to increase and our bed strength from 350 to 700 because of the increase in incidents in our city. And I'm sure that the very specific practical tips you have given will help our team to improve the patient care here. And thank you very much once again. And we will continue to keep in touch in terms of difficulties. Thank you very much.
Thank you very much. I really wish you all the very best of luck, and I'm sure you'll get through this.
Thank you.